Hi everybody, today we'll be discussing how to conduct an assisted breech delivery. Now once all the prerequisites are fulfilled, the patient is in the second stage of labor, and as we say crowning for cephalic presentation, here when we see the breech without separating the labia, it is called as the breech is climbing the perineum. So the word used here is climbing rather than crowning. The first thing we need to do is we should give an episiotomy, okay, because this will allow space for maneuvers, and especially when we're trying to deliver the aftercoming head, the episiotomy will be of great benefit. We bring her to the edge of the table and encourage her to bear down, and gradually the fetus will start descending down. Now, the first problem that can be encountered is that the legs may not come out by themselves. Many times they do, but especially in extended breech or frank breech, the legs may not come out. So here what can be done is two fingers can be inserted along the side, and on the popliteal fossa we give slight pressure. What does that do? The baby will then flex its leg and we can gradually deliver the leg. Similarly on the other side, this is called as Pinard's maneuver. We give flexion on the popliteal fossa and then we grab the foot and bring it out. Now what is next? We continue to let the patient bear down. The best thing to do at this stage is not to do anything. With contractions, with bearing down efforts, the baby will gradually come down. So we wait for the baby to descend down, it will keep coming down. At one point, the umbilicus will be seen. And with the umbilicus, we will see the umbilical cord. So a slight part of the cord, loop of the cord is to be kept onto the side so that there is no vasospasm by continuous pressure on the cord. So just keep a loop to the side, and it's always a good idea to wrap the baby in a breech towel. This again prevents vasospasm and premature breathing of the infant, of the fetus inside. Next, what do? The next thing to come out is the arms. So how do we know that it's time for the arms to be delivered? We will see the inferior border of the scapula. Now, if the scapula, the medial border is parallel to the spine, we know that the arms are not overhead or nuchal arms. We simply wait for them to come out, or you can put in a finger and deliver the arms like this. So we deliver the arm by putting in a finger like this, and similarly on the other side, we can deliver the arm here like this. The problem, however, comes is when the arms are nuchal arms, that is, they are overhead arms. So I'll just take this out to show you. The problem comes when the arms are at the back of the head or up like this. This is when the arms may be difficult. So in such a scenario, I'll show it to you outside. What we do is we rotate the baby, and we don't hold the baby like this, because holding the baby abdominally leads to a lot of abdominal trauma. So we hold the baby like this. Always hold the baby like this, the thumb on the sacral promontory and the fingers on the inguinal region anteriorly. Okay, never try to hold the abdomen by the baby with the abdomen, because it can lead to injuries. So we hold the baby like this, and what do we do in the nuchal arms? The arms will be like this. We rotate the baby so that one shoulder underlies the pubic symphysis, and we then release this arm like this, and then we rotate the baby by 180 degrees, and then this arm comes under the pubic symphysis and we can take it out. So that is Lovset maneuver, rotating the arms, the shoulders, so they lie under the pubic symphysis one at a time, and this helps release extended arms or nuchal arms. So once the arms are out, the next and the most important part is delivery of the aftercoming head. Now, one important thing during all this is to make sure that the back is anterior. The back, when it starts going posterior, that can lead to extension of the head. Remember, when the back is anterior, the head will remain flexed, and this flexed position is very important for the diameters to be small and delivery can happen, because in breech there's no molding, so you want the diameters to be as small as possible. So another important thing that we have to be careful with the aftercoming head is that there is a lot of risk of injury at the atlanto-occipital joint or at the cervical spine. So that's why delivery of the head is the most important. It's the largest part of the fetus and it can get stuck. So one of the common maneuvers we perform is called the Burns-Marshall procedure, or the Burns-Marshall maneuver. What is done here is that the assistant will be giving suprapubic pressure from the top here, and this will maintain flexion of the head. At the same time, what we will do is we will hold the baby's legs like this and sweep the baby over the maternal abdomen, and the baby comes out this way. This is called the Burns-Marshall technique. The other and the more commonly used technique, the more commonly advocated technique is the MSV maneuver, or the Mauriceau-Smellie-Veit maneuver. What do we do in this? The object again is to maintain flexion. So suprapubic pressure is kept by the assistant. I straddle the baby over my left arm in such a way that my two fingers will be on either malar eminence, and I will pull the baby towards myself. That will cause flexion. My right hand will be on the occiput in such a way, this finger will be right in the center and these two fingers on this side, and this will provide traction on the occiput, and this will cause flexion. So my right hand is causing flexion by pushing the occiput. My left hand is causing flexion by causing traction on the malar eminences, and gradually the baby comes out this way. So you can see how my fingers are. My fingers are going to be like this, my left hand fingers. My right hand is going to push the occiput like this, and the suprapubic pressure also will help in maintaining this flexion. A third and a more safer way is by using a Piper forceps, This is not a Piper forceps. This is just to show you how we do the forceps delivery in aftercoming breech. We use, if you don't have a forceps and a Piper forceps, any forceps with a long handle like a keyland forceps or a low forceps can also be used in place of a Piper, but not this one. This is just for demonstration purpose. This is an outlet forceps. Now, how do we do a breech delivery in, how do we do a forceps delivery in breech? Again, we take the breech towel and you ask the assistant to lift the baby's body up like this. So this gives us space from below. Then we take the forceps, okay, and how we usually apply forceps. So the left forceps will go in first. The left one held in the left hand will go, the lower one will go in first. Okay, and then you ask your assistant to hold it. Then you take the other forceps, the right one in the right hand. It will get locked. And then you gradually deliver the baby's head like this. So this is how forceps delivery is done for the aftercoming head in breech.